Hello, everyone. Yes, so our first speaker for this session is David Harrison. David is co-director for ICNAC, which is the Intensive Care National Audit and Research Center in the UK. As many of you know, ICNAC is one of the premier ICU registries that has been around for more than 20 years in the UK, and they have, out of ICNAC, they have published quite a bit of embedded trials in different aspects of critical care, especially today for sepsis. David is an honorary professor of medical statistics at the London School of Tropical Medicine and Hygiene, and he'll be presenting some data to us about sepsis in the surgical population. Thank you so much. David, over to you.
I'm really going to try and set the scene here and talk a little bit about surgical patients, multi-organ failure in the SOFA score, and provide a little epidemiological data really around that. So I have no conflicts of interest to declare for this. So in the UK, we have the case mix program, which ICNAC coordinate. This is the national clinical audit of adult critical care for England, Wales, and Northern Ireland. We have 100% coverage of general intensive care units across the country, but incomplete coverage of specialist and high dependency units. So just a kind of flagging up front that this epidemiology will be slightly weighted towards the level 3 intensive care patients and general surgery. And the case mix program is a benchmarking program. So we're essentially reporting back to these critical care units on them risk-adjusted mortality and other quality indicators. So for this presentation, I've focused on the last year of data. So looking at a data set of nearly 180,000 admissions to 257 critical care units during 2023. So how have we defined surgical sepsis? Well, first off, sepsis, we're applying to the sepsis 3 definition, or our kind of closest way to apply that in the routine data. So to do that, we're looking at patients with a primary or secondary reason for admission to the critical care unit that's recorded as being infection or infection related, and a SOFA score of 2 or more from the first 24 hours in the critical care unit. And in terms of surgical sepsis, we define this here as patients that had a surgical procedure within 24 hours prior to admission to critical care. So looking at that almost 180,000 admissions for 2023, what we can see is that 7% of those admissions, or 1 in every 14 admissions to critical care, meet that definition of surgical sepsis. So that's just over 12,000 admissions in England, Wales, and Northern Ireland during 1 year. So those make up 7% of all admissions, as I say. They're also just over a quarter of the sepsis admissions, so non-surgical sepsis being another 19% of admissions. So what do these surgical sepsis admissions look like? Well, the mean age of admissions is 63 years, just over half a male, which is fairly typical for critical care admissions in the UK. 9% of those admissions are from non-white ethnic groups. In England and Wales as a whole, at the last census a couple of years ago, 18% of patients were from non-white ethnic groups. So those non-white ethnicities are somewhat underrepresented in the surgical sepsis admissions. 63% of these patients are either overweight or obese, which is actually pretty much in line with overall national figures for overweight and obesity in the UK. And almost all of those surgical sepsis patients came directly to the critical care unit from theatre following their surgery. In terms of surgical specialties, almost 3/4 of all of these surgical sepsis admissions were classified as general surgery, with trauma, orthopedics, and cardiothoracic being the next largest group, but much smaller in numbers. So the topic I was given is multi-organ failure in the SOFA score. So this just shows the distribution of the SOFA score among those surgical sepsis admissions. As you can see, 2 is the minimum because that's part of the criteria for sepsis 3. So a range of SOFA scores from 2 anywhere up to 18. But the majority of patients with sepsis scores in the range of 2 up to about 9 or 10. The median SOFA score there being 5, the interquartile range, so covering half of all patients between 3 and 7. But the SOFA score as a summary doesn't really tell the whole story. And I think it's quite interesting to look at the breakdown across the different organ systems in SOFA. And we see really quite different patterns in those different organ systems. And what we can see here is that in the respiratory system here, you can see that actually most patients in the respiratory system are scoring at least 2 or more points there, predominantly scoring 2 points in the respiratory system. In the cardiovascular system, interestingly, more than a third of patients are scoring 4 points for their cardiovascular organ dysfunction, almost all through high enough doses of noradrenaline to trigger that 4 points for cardiovascular SOFA. And then across the other organ systems, much lower proportions of patients that scoring high numbers of points, with around 60% of renal patients patients not receiving any points for the renal organ, up to over 80% of the surgical sepsis patients not scoring points on the neurological organ dysfunction. And in terms of multi-organ failure, if we combine those different organs together, so considering organ failure to be a SOFA score of 2 or more points in a single organ, we can look at how many organ failures each of these patients have, and they see the distribution of that here. So 0 organ failures is possible by scoring only 0 or 1 point for any given organ. Most patients here have at least 1 organ failure, so at least 2 points in one organ system, and then decreasing numbers with greater numbers of organ failures. And in terms of multi-organ failure, pretty much exactly half of patients in this surgical sepsis cohort meet that criteria of 2 or more SOFA points in 2 or more organ systems. Moving on to the outcomes for these patients, what we see is that overall 15% of the surgical sepsis patients die in acute hospital following their critical care episode, with about 2/3 of those deaths happening in critical care, and the last third of deaths happening in hospital after discharge from critical care. So overall across the year, we're seeing just under 1,800 patients dying after an episode of surgical sepsis. And as we would expect, that hospital mortality, 15% overall, varies substantially according to the SOFA score. So ranging from 3% mortality for patients with a SOFA score of 2, up to 59% mortality for patients with a SOFA score of 12 or more, and a full range in between. And we can look also at mortality according to the number of organ failures. And again, that same pattern as you'd expect of great increase in mortality with organ failures, a range there from 3.5% for the patients with no organ failures, up to 46% for patients with 4 or more organ failures. But the number of organ failures, again, doesn't tell the whole story. So quite a complicated slide here, but I'll just try and take you through it. This is looking at the combinations of different organ failures on the SOFA score. So on the left here, in the orange crosses, we have the patients with only single organ failure. And you can see even within those with single organ failure, considerable variation in the mortality depending on which organ failure. So respiratory single organ failure is relatively low compared with neurological, as the single organ failure considerably higher. And then we see again considerable variation across the patients here with 2 organ failures, and again the patients here with 3 and with 4 or 5. I've only shown here combinations that occur in at least 50 patients. But actually, the biggest pattern we see among these is really that a combination of cardiovascular and renal organ failure stands out as being a combination of organ failures with particularly high mortality. So amongst all of the patients here with 2 organ failures, you see that if that combination of 2 organ failures is cardiovascular and renal, that really stands out as being high. Again, among those here with 3 organ failures, the combination here of respiratory, cardiovascular, and renal. So there's that cardiovascular and renal combination again, giving much higher mortality. So in summary, in 2023, surgical sepsis accounted for 1 in 14 critical care admissions in the UK, or a quarter of all the sepsis admissions. Half of those had multi-organ failure. The overall hospital mortality, 15%, but that varied substantially by both the SOFA score, the number of organ failures, and the combination of organ failures. And the combination of cardiovascular and renal organ failure was associated with particularly high mortality of 30 to 60%. Thank you very much. I'm happy to take any questions.
Thank you so much for that very eye-opening presentation. So the one question I have is the role of registries in intensive care in medicine in general. ICNAC has, for the most part, led the way, especially with regards to intensive care registry. For countries and places that are just starting out, in terms of in Uganda, we've just started a registry, and it's both local and part of a network that's being supported from the UK as well. What key lessons would you give to us who are starting out with registries?
I think the biggest lessons, I would say, I personally learned from those that have gone before. So there are fantastic initiatives like the Logic group that are linking together registries all around the world. I think that's gives a great opportunity for a new registry to learn from others. And then I think the other key message from our 30 years it is now that we've been running would be that really the buy-in of the clinicians on the ground in the intensive care units has really been the key factor for us. That it's been about getting the clinicians to want to engage and improve the care that they deliver, and that's what really makes the program work. If we were kind of government controlled and trying to tell people what to do, I think that would have been a much harder slog than really the way we've set up is we're independent and we try and work with the intensive care units. So we haven't got 100% of critical care units by everyone being told they must do it. We've got 100% by bringing them with us, and everyone wanting to engage and improve their care.
Thank you for that. Do you have any programs within ICNAC that would support those who are coming after you in that regard? And if any, is there one that people can reach out to for support and collaboration?
We don't have any specific programs for that, but we are always open to collaboration, always keen to hear from people that are trying to do similar work around the world, and very, very pleased to work with anyone and try and support that aim of just improving the critical care we give all around the world.
All right. Yeah. Thank you. One more question from Ethiopia. Now they're starting to come in. Sorry about that. Did you have a chance to look at risk factors? And then is the mortality similar in all levels of intensive care? I think maybe just some clarification on how UK intensive care works would be helpful.
Sure. So the majority of critical care, or at least general critical care in the UK, is delivered across kind of combined critical care units that will provide both level 2 and level 3 high dependency up to intensive care. For surgical patients, there is a fair bit of kind of surgical HDUs, enhanced care, overnight recovery, quite a mixture of kind of different levels of care, potentially below what we would kind of class as full critical care, and we don't really have a good picture on what's going on in those types of units. I mean, I would say, so, although I didn't look at it specifically within that presentation, certainly we would expect much lower mortality in the kind of high dependency and enhanced care areas, which we do have some of in the casings program, than in a full level 3 intensive care unit. But it's because it largely follows the organ dysfunction. I mean, most of those multi-organ dysfunction, ventilated patients, or at least patients ventilated beyond what they need just for the surgery, are generally going to be in those level 3 units. So it will correlate a lot with the organ dysfunction that I showed.
Yeah, thank you. Nala from Sudan is asking about antimicrobials for ICU patients during surgery, if you have that sort of data. I mean,
it's an interesting question, but we don't have any data on the antimicrobials they receive. So the data set is tailored around the fields we need to run the benchmarking program, which does include the SOFA scores, but we don't have detailed treatment data.
Yeah, and then Enias from Rwanda is asking about any specific empiric tests to be done for early detection other than calcitonin. I think Enias, we'll have answered in the next session, one of the next sessions, and some of the others. I think in resource-constrained nations, can QSOFA be used in place of SOFA? That's Shem from Kenya. Yes, QSOFA just has three physiologic variables that you can measure. You don't need any sort of machine or anything. I think what we'll do now is we'll try and look at these questions in the chat and answer them in real time. Thank you so much, David. Thank you so much once again.
Thank you.
Yes, thank you for staying with us in this session. I would like to introduce Frédéric Michard. He's a very, very world famous critical care physician and researcher from both North America and specifically France, who will be whose work has spanned fluid management, hemodynamic monitoring, and now talking about AI-enabled tools and wearable sensors. His recording, his presentation is pre-recorded. I hope we might be able to have him with us at the end to answer some questions. So please enjoy this talk.
Hello, everyone, and thank you very much for the invitation to be part of this session on the need for early diagnosis and treatment of sepsis in surgical patients. I have been asked to focus on electronic sepsis surveillance and early warning tools. My name is Frédéric Michard. I'm an intensivist, a French intensivist. I spent some time doing research in the US, and I'm today leading a research and consulting organization in Switzerland, where we focus on digital innovations with medical applications. So, as you know, many patients go to the hospital for surgery and have to stay for complications. We know from the large international surgical outcome study that around 17% of patients undergoing surgery develop at least one postoperative complication. It's 27% after a major surgery. And these complications are responsible for over 4 million deaths worldwide within 30 days of surgery. That's more than the number of deaths attributed to HIV, malaria, and tuberculosis combined. If postoperative complications were a disease, that would actually be the third leading cause of deaths on the planet. So clearly, postoperative complications are a burden, a clinical and economic burden. And as a matter of fact, many of these complications are infectious complications. And it's very important for our topic today because it means that surgical patients are obviously at high risk of developing sepsis. What is the current clinical surveillance strategy in these patients? Most of the time, nurses are going to spot check vital signs from time to time, every 4 hours, 6 hours, looking for abnormalities. And typically in sepsis, we may observe a rise in heart rate, a decrease in blood pressure, a rise in respiratory rate, and of course, an increase in temperature. Sometimes nurses aggregate vital signs together to calculate warning scores. Here you have the example of the news used in the UK. These warning scores have been designed to flag deteriorating patients. For sepsis, as you know, a specific warning score has been proposed a few years ago, the QSOFA, the Quick Sepsis-Related Organ Failure Assessment Score. But studies have shown that actually classic early warning scores, such as the NEWS or the MUSE, which is a modified early warning score, are actually have a better performance than the QSOFA. Electronic surveillance is possible as soon as you store vital signs and biological information on an electronic medical record system. And so it enables integration of vital signs and biological data, the automatic calculation of warning score, and maybe more importantly, it enables, the automatic alert of nurses and physicians in case of clinical deterioration. And we have today evidence that this electronic surveillance system may help to improve outcome. This is, I think, the most important study published so far a few years ago in the New England Journal of Medicine, reporting a significant decrease in mortality with electronic surveillance when compared to a classical intermittent spot check. Sepsis sniffers have been developed as well with AI, with predictive analytics, more specifically with machine learning algorithm. Using data from the EMR. So here I share with you an example done in the ICU to predict sepsis. This algorithm was using 65 variables from the EMR, including vital signs, and was able to predict sepsis with a sensitivity of 85% and a specificity of 67%. It's actually somewhat disappointing because the specificity of 67% means 33% false positive. So clearly, you could not take the risk to treat patients just based on this prediction. You could possibly, use it to perform bacteriological samples earlier, knowing that in many patients, actually, you will probably do these samples despite the fact they would never develop sepsis. So I'm not sure it would be interesting from a cost-effectiveness standpoint. Another pretty disappointing study regarding AI, it's this time we're not in the ICU, we're on regular wards. This is the external validation of a widely implemented in the US sepsis prediction model. Again, reporting disappointing results with poor discrimination and calibration in predicting the onset of sepsis, raising, of course, concerns about sepsis management on a national level. So you see regarding AI, it's of course very hype, very trendy, but so far a bit disappointing, at least as of today. In contrast, continuous surveillance, I think, is much more promising. One of the major drawbacks of spot check is that they are intermittent by nature. Typically, a nurse who would spot check vital signs every 4 hours would actually leave the patient without any surveillance 98% of the time. So now we are able to monitor vital signs continuously with non-invasive sensors. We can quantify how much we miss with intermittent spot check. And this is a very interesting study from the Cleveland Clinic, so as you know, a top-level hospital. And when nurses were spot checking vital signs every 4 hours, they actually missed 82% of hypoxemic events and 79% of hypotensive events. So that's why with Dan Sessler and others, we proposed already 6 years ago to upgrade the way we monitor patients on regular wards, what we called World Monitoring 3.0, using wireless wearable sensors. Here you have examples of adhesive patches, but they are today more sophisticated and complete system, giving you the opportunity to monitor continuously, automatically, wirelessly, if not all, at least most vital signs. It's very important to understand, what we can expect from these tools. It's not to prevent sepsis or any other complication, but simply to detect them at a pretty early stage. The idea is to prevent catastrophic events requiring rapid response team activation or typically ICU admission. So are these tools effectively or really useful to improve patient safety? Yes, we start to have answer to that question. Here you see large studies reporting clinical outcome benefits after the implementation of continuous monitoring on hospital wards. 5 large studies, these are before-after comparison studies, showing a decrease in rescue event, a decrease in ICU transfer. There is even one reporting a decrease in hospital mortality. I have updated this table for the presentation. I think today there are at least 9 studies, and you see that 7 out of these 9 studies were done with a wireless system. This is, I think, the first and the only propensity matched study published on the topic. It was led by Ashish Khanna from the US, and you can see in this study we compared the outcome of patients who had classical intermittent spot check on the left-hand side, or on the right-hand side, continuous wireless monitoring, and we were able to report a significant difference with regard to ICU admission and mortality. So before closing, just a few words about the future. The future could be, of course, early detection of sepsis and any other complication from home in patients who have been discharged from the hospital after surgery. We started to use home monitoring during the COVID-19 pandemic, asking patients to self-monitor, or at least self-check their oxygen saturation. We can imagine to do the same with sensor monitoring temperature or heart rate or blood pressure continuously, and imagine that we will be able to detect sepsis from home pretty easily in the near future as well. So in conclusion, I hope, like me, you agree that it's time to rethink the way we monitor patients on regular hospital wards, and particularly on surgical wards. Infectious complications are pretty common after surgery, so these patients are at high risk of developing sepsis. Clinical deterioration may be overlooked for hours, mainly because of the intermittent nature of spot check. Finding patients before they crash may be the next major opportunity to improve patient safety. Electronic surveillance is useful to automatically alert in case of clinical deterioration. However, the value of AI-enabled sepsis sniffers remains to be established. Interestingly, wireless wearables now exist for the automatic, continuous, and mobile monitoring of vital signs and the early detection of sepsis in surgical wards and beyond. With that, I thank you very much for your attention. If you have any questions, feel free to contact me by email. Thank you very much.
Yeah, thank you very much, Frédéric. That was a pre-recorded presentation, and he has graciously accepted to answer your questions by email. I think what we'll do, we'll move to the next speaker. It's a very illustrious panel. So Jean Duvel is from Belgium. He's also a very, very, very highly published and resourceful intensivist. His major focus right now is on antimicrobial therapies, and he's going to talk to us about source control. Over to you, Jean. Thank you.
Thank you, Arthur. Thank you very much for this kind introduction. I'll start my presentation, which will be on source control. We've learned already of various different topics today, and I think when it comes to discussing the early management, so beyond, of course, identification, when we discuss the management of infections, the management of sepsis and septic shock, we often discuss antibiotics, but source control, the source of the infection, identifying and treating this is extremely important. And I will, in the next 10 minutes, elaborate on why that is and how we can go about this from a practical point of view. So these are my disclosures, none of them, in fact, relevant for this particular presentation. Brief recap, what exactly is source control? Source control are actually everything we do, all the measures we do to essentially eliminate the source of infection and also control ongoing contamination. And these are two very important elements. Equally important, though, is restoring pre-morbid anatomy and function. And this is particularly relevant when it comes to abdominal infections, when there is an issue with the continuity of the GI tract, for instance. But these three goals are very, very important. Not only eliminating the source, but also controlling ongoing contamination. What are the strategies that are typically used in source control? It's about draining an abscess. It's about draining an infection. It's also debriding, removing all the necrotic tissue, as well as decompression. And again, this definitive repair, this restoration of anatomy and function. Simply said, this is how source control relates to other treatments in patients with sepsis and septic shock. Of course, we need to give antimicrobials to our patients, but rest assured that controlling the source of an infection is of key importance. And if you do not, if you're not able to control the source of infection, then nor your antibiotics, nor your sepsis interventions, specific sepsis interventions, will be effective. Now, while, for instance, antimicrobials may be adequate to briefly kind of control or contain the infection, in the end, you will need to control the source. And there's different aspects as to why this is important. There is timing, and I will briefly elaborate on that, but there's also the methodology and the different strategies that we have available. Of course, in 10 minutes, it's possible to cover everything, but I will briefly touch upon it. But do not forget that it's also about the adequacy. And we should not forget that fully controlling the source is important. It's not just putting in a drain, it's also making sure that the abscess or the infection is adequately controlled. So these are the main contributors to clinical success. Now, while most of us, or a lot of us, think of abdominal infections as the type of infection where source control is relevant, actually it's much broader. And I think almost in every organ system, infections may occur that require source control. So this could be the intracranial infections, for instance, but also chest infections, joint infections, urinary tract infections, and of course the abdomen, skin and soft tissues. So you see that this really is relevant for a broad range of infections. And it's clear to me that controlling or considering source control should be something that we consider in every type of infection. I already mentioned that timing of source control is important. I'll briefly discuss this study that was published 2 years ago, a large study looking at the association between time to source control and the outcome. So this was from the US, large number of patients, almost 5,000 patients from 14 different hospitals, where source control early versus late was compared. Looking at community-acquired sepsis, an average time to source control of about 4 to 15 hours. And roughly 1 out of 4 patients actually got their source controlled within 6 hours. So this is more or less the description. But let us have a look at the type of infections and whether source control really made a difference. And this is a summary describing the odds of mortality in different subgroups. You can see that overall, there is a clearly decreased likelihood of 90-day mortality if the source is controlled early. But if we then dive in a little bit deeper, you will see that patients with a higher SOFA score, like 5 or more, that actually benefit the most of having their source controlled early, whereas for patients with lower severity of illness, it did not really make a big difference. And then looking at specific anatomical sites, you can see that, for instance, for GI tract, abdominal, and also soft tissue, those were the infections that actually benefited most from early intervention. So it appears that not all infections are equal, and some of them really benefit more of early source control. This is the same, but looked at it differently, because clearly there is a time-dependent effect. This is the crude and risk-adjusted mortality, as you can see here. And as the time to source control increases, so does the 90-day mortality. And even within 6 hours, it seems that even faster, earlier source control is more beneficial. When we look specifically at explorative laparotomy, so abdominal infections, you can see that this is a much steeper curve. So the importance of source control clearly even more relevant there. And compared to soft tissue debridement, again, necrotizing skin and soft tissue infections, these are the type of infections where we know source control is critical. Again, showing you that for this type of patients, indeed, this relationship is clearly there. Where we look at the patients who were treated with percutaneous drainage, this effect seemed not to be present. So the timing to source control there is not clearly there. Does this mean that we have to wait, or we can wait in case we drain? Of course, this was not studied, and we need to also consider that the accessibility to drainage may be different, and that also the adequacy, the completeness of draining an infection may be different when percutaneous draining an abscess. In this recent study in the Journal of Intensive Medicine, I summarized the recent literature, and what is really striking, these are the first authors as well as the type of population. It's immediately striking that these populations are quite different. So I think it's very important when you read about source control and early source control that you carefully check what patient population was under study. For instance, intra-abdominal infections, community-acquired sepsis, patients operated for perforated peptic ulcer, cholecystitis, septic shock in the ED. So you see highly variable patient populations in these studies. Also, when looking at the definitions, clearly there is no consensus as to what really defines early, although in a lot of studies, 6 hours seems to be the cutoff that is used mostly. And summarizing the impact, you can see in green, those are the studies that were able to show a benefit of what was considered early source control in that study. You can see that a number of studies were neutral and at the bottom, but clearly there is no single study that shows that there is a negative effect, that there is an adverse effect of controlling the source early. The evidence, I think, is mounting that, yes, indeed, it is important. Now, you may say this will be an area where we will have no randomized controlled trials. Well, that's what I thought until recently. I came across this study. You may say, well, this is not really sepsis, and you are right. These are patients with presumed uncomplicated acute pancreatitis, but still almost 2,000 patients in 3 Finnish hospitals. This was a non-inferiority RCT comparing source control within 8 hours or appendectomy within 8 hours or within 24 hours. Essentially, there was no difference. Mortality, of course, was non-existent in this type of patient populations, and the complication rate was similar. But I just wanted to share this important study, not only because it's the only randomized controlled trial that I'm aware of in this field, but it also shows you again that the severity of the disease, that not every patient, every infection is equal, and we need to differentiate and try to select the patients that benefit from early source control. Surviving Sepsis Campaign guidelines also do have some guidance on this one, and this is the recommendation for patients with sepsis and septic shock. The recommendation is to rapidly identify the specific anatomical diagnosis and assessing whether the source needs to be controlled, and if it's the case, to do this as soon as medically and logistically practical. So this is kind of a vague statement suggesting that indeed, of course, it is important and to do it as soon as possible. Now, from a practical point of view, I think the timing of source control is essentially determined by these factors: the site of infection with abdominal and skin and soft tissue clearly ranking higher, the degree and the dynamics of organ dysfunction with more organ dysfunction, meaning that you need faster source control, and the magnitude of ongoing contamination. If you have a large hole in the bowel and the GI tract content is pouring to the peritoneal cavity, this is the kind of source you want to control earlier, I think. And patient physiology. Patients may have coagulation disorder or coexisting diseases that are uncontrolled. And sometimes it's better to wait just a little bit, correct these abnormalities, and then proceed to source control. Now, based on this, we've identified a three-tier approach to source control. With category 1, those are the patients where you want to have the source control as soon as possible, as soon as the diagnosis is suspected or established. Necrotizing infections, intra-abdominal infections, typically in this category, especially when there's rapidly deteriorating organ dysfunction or abdominal compartment syndrome. Large bulk of patients, these patients are stable. They have limited the severity of the disease. There's time to correct some metabolic disorder, but of course, it's still important. And, when there is the time, when there's the possibility, do it the sooner, the better. And the bulk of the infections fall in this category 2 and category 3. This is a separate category. I think this is where you want to wait until the infection is demarcated with pancreatic necrosis as infected pancreatic necrosis as a typical example. So 3-tier approach, 1 really fast and the others more based on the physiology. Just before finishing, a short word about the methodology, because there's a lot of debate as to what is the best strategy. And of course, we need to make sure that we avoid adding more harm to our patients. I think the main determinants are both patient and hospital related. We already discussed the hemodynamics, the physiology of the patient, prior surgery, especially when considering the abdomen. Surgeon may not want to go back into the abdomen, which would then prioritize percutaneous drainage, but also hospital factors. And I do acknowledge that surgeon experience, especially with these sometimes complicated infections. Sometimes it's better to wait a few hours for a surgeon who has proper experience. And we do also have to acknowledge the availability of ORs and of radiologists to assist us in percutaneous drainage of infections can be important. There's not a lot of literature on what is the best. The study kind of suggests that open surgery is associated with a higher mortality, but I do think that the patient selection is often present in these typically retrospective studies. Source control strategy, simply said, percutaneous drainage versus surgical. Percutaneous primary choice in a lot of these infections, especially in post-op patients, post-op abdominal surgery patients, and when there is this hostile abdomen that is difficult to access. But still, in case of diffuse peritonitis, ongoing contamination, and failed percutaneous drainage, I think it is important that surgical drainage clearly remains an important option. So before finishing, this is my clinical algorithm. When approaching a patient with sepsis or septic shock, antibiotics and tissue perfusion, of course, are important, but in parallel, we need to think of identifying the source and asking us the question, is it necessary to control the source of infection? If it is, then consider three different things: timing, and identify the best time to do this, the modality, and also the adequacy with a careful follow-up and prior identification of endpoints. So in conclusion, it was a challenge, of course, in 10 minutes to convince you that source control is critical, but I hope to have shown you that indeed it is pivotal for many infections, that it should be considered in different type of infections and not just abdominal infections. And the adequacy, the timing, and the strategy used will determine the outcome. Early intervention, yes, especially for the most severely ill patients, particularly in abdominal and skin and soft tissue infections, as I showed you before, with also shocked patients being an emergency as well. I do want to emphasize, of course, that this is a multidisciplinary approach where you consult with surgeons, with radiologists, or whoever would do a percutaneous drainage. And moving towards this patient-tailored decision-making is definitely the future. With this, I would like to end. And of course, I will be happy to take questions as well.
Thank you so much, Jan. Very interesting talk. We have, I have two questions. Well, I think in light of this Congress being sepsis, I think, some of the questions might be a little bit outside the domain of your talk, but nonetheless, you are our resident expert. Miguel from Spain asks, are there any options to achieve, and he does quote unquote, source control in respiratory tract infections, including hospital-acquired, all types of infections? That's from Miguel in Spain. This, I think, was not related to this talk, but being an expert in this area, you could help him with some answers.
Well, I think you have to consider source control in any type of infections, including respiratory infections. And of course, a pulmonary normal pneumonia, so to speak, may not readily require source control, although we may see complications such as an empyema developing, which clearly, of course, is very important to early identify it. To some extent, you can also consider, aspiration and expectoration of sputa as a way to control the source of infection. In some situations, when patients have been intubated for a prolonged period of time, you may see a lot of contamination on the endotracheal tube or on the tracheostomy tube, for instance, in some patients. I'm not saying that we should routinely exchanging these tubes, but I think in quite some situation, and probably more situations than we would routinely think of, this idea of removing the focus of infection is important. I mean, it applies to central venous catheters. It applies to stones, whether it's in the kidney. It applies to urinary tract, urinary catheters, etc., etc. So source control is not just for the abdomen. Source control needs to be considered in every patient that you encounter with sepsis and septic shock. And I admit that probably it will only apply in 1 out of 3 patients, or maybe 1 out of 2, depending on your case mix. But still, I think it's our responsibility to just, reflect on, does the patient need source control?
Yeah. Thank you, Jan. I've had situations where I have had to exchange the tube when I was doing bronchial toilets. So yeah, that's one of the things. I'm reading down a list of questions. Some are interesting. Let me see. How do healthcare providers assess the adequacy and effectiveness of source control measures in sepsis management? That's from.
Thank you.
Yeah.
Who posed that question, Arthur?
Is a tool from the Gambia
From the Gambia.
Yes.
Well, I did mention it, of course, that checking the adequacy is also really important, and confirming that indeed the source of infection is controlled, and this can be particularly challenging. It is quite common that indeed surgeons, especially in abdominal infections, of course, will be very happy with the surgical intervention, and they will reassure you that the source of infection has completely been controlled. Now, there is evidence, though, that while this perception may be true immediately post-operatively, in a lot of the patients, ultimately, there will be a recurrent infection. There could be a leak. There could be, a residual infection that persists, a residual collection. So there's many different reasons. And it does happen, and it happens much more often. And depending on severity of illness, up to 50% of the patients may have not achieved source control. It may not have been possible, while still immediately post-operatively, the surgeon will tell you that the source of infection was controlled. Now, you need to be very careful, and I'm sure there are also surgeons listening today, and often they perceive this failed source control as a kind of personal failure of the surgical technique or approach, which clearly is not the case. And I always explain that this is not about the surgeon failing, it's the patient failing. The patient physiology is not able to fully control the infection, to resolve the residual collections that are present. And this can have, of course, many different reasons, or the wound healing. If there was a anastomosis made in the abdomen, the wound healing may be incomplete. And this has nothing, again, to do with the technicity of the intervention, but it's purely based on the patient who is just not able to get on top of this infection. So I think it's a great question. My answer is yes, it's very important. And the way I also like to approach this is that when a patient comes back after a source control intervention, that you already talk to the surgeon and you agree on preset endpoints. You agree, for instance, that if the patient does not recover in 3 days, maybe we need to have a very low threshold to get in, and discuss this up front, like what can we expect and what will we do if things do not resolve in 3, 5, or whatever days. So already agree up front.
Yeah, thank you, Jan. My colleagues from around the world, we're very tight on time. We'll try to answer your questions in the chat because we have other sessions. So I just want to thank Jan so much for everything, for gracing us with your presence, and and all the best. Thank you very much, Jan.
Thanks for the opportunity.
Our next speaker is Lena Napolitano. She's also pre-recorded. And so she's going to talk to us about research priorities in sepsis and septic shock in surgical patients, and this speaks to the questions that you're asking in the chat. So let's listen to her, and then we can discuss later. Thank you very much.
Good morning, everyone. I'm Lena Napolitano, a surgical intensivist from the University of Michigan. Thanks very much for the invitation to participate today. I've been asked to review the topic of research priorities in surgical sepsis. Let's first review the top 6 clinical research priorities from the Surviving Sepsis Campaign Research Committee from a modified Delphi consensus process. First, can targeted, personalized, or precision medicine approaches determine which therapies will work for which patients at which times? What are the ideal endpoints for volume resuscitation and how should it be titrated? Should rapid diagnostic tests be used in clinical practice? Should empiric antibiotic combination therapy be used? What are the predictors of sepsis long-term morbidity and mortality? And finally, what information identifies organ dysfunction? An additional top 6 research priorities address the important issues in administration, epidemiology, scoring, and identification of sepsis. First, what is the optimal model of delivering sepsis care? What is the epidemiology of sepsis susceptibility in response to treatment? What information identifies organ dysfunction? How can we screen for sepsis in various settings? How do we identify septic shock? And finally, what in-hospital clinical information is associated with important outcomes in patients with sepsis? So should the research priorities be any different in surgical sepsis? In general, not, but surgical infection in sepsis includes a large number of diagnoses, from abdominal sepsis to necrotizing soft tissue infection to mesh and hardware and burn infections, and each of these has their individual research priorities. Sepsis is clearly associated with significantly increased mortality in surgical patients, as in this study after cardiac surgery, with an over 6-fold higher risk of mortality in patients with sepsis. Similarly, in our study of over 30,000 trauma patients, sepsis was associated with significantly increased mortality, 7% versus 23%. Increasing injury severity, and particularly severe traumatic brain injury, were the 2 greatest risk factors for sepsis and trauma. I'll focus on 4 areas which I believe are important research priorities for surgical sepsis. First, early recognition and diagnosis of sepsis is key to achieving successful patient outcomes. However, the heterogeneity in sepsis makes early diagnosis very difficult. Automated sepsis prediction tools and models have existed for years, but have produced really variable results. A commonly used predictive model, the EPIC sepsis model, or ESM, has not demonstrated consistent improvement in patient outcomes. In a recent report in JAMA, performance of the EPIC sepsis model in 9 hospitals with over 800,000 patients found that it was negatively correlated with the incidence of sepsis, comorbidities, and cancer prevalence. Our group here also published the reduced sensitivity, specificity, and positive predictive value of the ESM, as well as an unacceptably high rate of false positives. Sepsis is the most common postoperative complication in emergency general surgery patients in an American College of Surgeons National Surgical Quality Improvement Project database study of over 59,000 patients. And particularly those who required emergency laparotomy were at the highest risk for septic shock at over 15%. A clear research priority is to determine the optimal tool for early identification of sepsis in surgical patients. The Potter tool is an artificial intelligence-based calculator for the prediction of complications in emergency general surgery, or EGS. This machine learning algorithm was trained with all patients in the ACS NISQIP database over 10 years. Interestingly, Potter had the highest performance in predicting septic shock. The Potter smartphone application is shown on the right. We are really hopeful that these surgery-specific algorithms will be able to augment our clinical judgment with early sepsis prediction. Another research priority in surgical sepsis is how to achieve uniformity in reporting whether source control is adequate and effective during sepsis management, and also when it was achieved, time to definitive source control. Importantly, failed source control is difficult to diagnose, and we currently have no standardized accepted definition. Source control is really critical and an important element of the treatment of surgical sepsis. The guidelines recommend achieving source control as soon as possible. Operative, non-operative, or combination approaches are all acceptable. Since the goal of source control in surgical sepsis is to eliminate the source of infection, we need further research into the impact of the type and the timing of source control in all types of surgical sepsis. We know that time to definitive surgical debridement has the most impact on survival in necrotizing soft tissue infection, as you see in the middle there. But it is unclear if time to definitive source control should be an important target in all surgical sepsis treatment, as there are no prospective trials. A recent cohort study of community-acquired sepsis across a 14-hospital system in the U.S. reported that source control within 6 hours was associated with a 29% decrease in 90-day mortality compared with those who had source control beyond 6 hours. Patients with gastrointestinal, abdominal, and soft tissue infections benefited most from early source control when compared with orthopedic and cranial infections. So should we uniformly adopt a 6-hour rule for source control in all of our surgical patients? It's not quite yet known. Another research priority is whether a personalized approach is better for hemodynamic management in surgical sepsis. Although the guidelines recommend fluid resuscitation of 30 cc's per kilo over 3 hours, this can be potentially harmful in some surgical patients and cause complications at the surgical site. It is well known that liberal fluid management in the perioperative period is associated with increased morbidity and mortality, including increased anastomotic leak, as you see in the lower left, abdominal compartment syndrome, and cardiopulmonary complications. Both excessive fluid and vasopressor agents are detrimental for anastomotic healing, so achieving an appropriate balance in personalized hemodynamic management is critical. Research priorities should assess whether resuscitation based on real-time dynamic cardiac and perfusion assessments, as in the algorithms shown here, are associated with improved surgical patient sepsis outcomes. We still do not know optimal blood pressure targets in surgical sepsis patients. The SepsisPAM trial reported that a high blood pressure target was associated with higher rates of atrial fibrillation and less renal replacement therapy in chronic hypertension patients, and overall no difference in mortality. In contrast, the 65 trial found that permissive hypotension with a lower MAP target had no impact in older septic shock patients requiring vasopressors. And this reinforced the logic that blood pressure goals can potentially be personalized and that a lower MAP target may be acceptable. Additional studies are clearly needed in surgical patients to validate that personalized blood pressure targets in septic shock should be based on their premorbid and baseline blood pressures and not a standard MAP target for all. Next, should we use tissue perfusion or lactate as our resuscitation goal? The Andromeda shock trial found that a simple clinical bedside peripheral perfusion targeted resuscitation strategy using capillary refill time, or CRT, reduced organ dysfunction and 28-day mortality in septic shock compared to lactate. Importantly, this trial found that the majority of patients, 72%, were fluid non-responders at hour 2 after enrollment into the study. The guidelines suggest that both CRT and lactate be used to guide sepsis resuscitation, but aiming for lactate clearance may result in greater fluid resuscitation, which may be harmful to surgical patients. The Andromeda Shock 2 trial is an RCT that started enrollment in October of 2023 and aims to compare a resuscitation strategy based on hemodynamic phenotypes and normalization of peripheral perfusion versus standard of care in septic shock. It will examine the hypothesis that a CRT-targeted resuscitation strategy based on hemodynamic phenotyping and tiered management in a decision tree, shown on the right, using bedside clinical parameters, including pulse pressure, diastolic blood pressure, fluid responsiveness, and cardiac performance, can further decrease mortality in septic shock compared to usual care. And this will include personalized vasopressor and cardiotonic drug management as well. Finally, personalized and precision immunotherapy is an important research priority for the treatment of sepsis in surgical patients. Infection initiates sepsis, but the clinical disease of sepsis arises through the innate immune response of the host, the patient, to the pathogens, and host microbial interactions are very complex. The biologic complexities of sepsis create great challenges in the development of effective sepsis treatments. In addition to changing organ dysfunction over time in sepsis, there are also significant changes in biologic responses over time. An individual patient's immune response, coagulation, and endothelial activation can change rapidly over time, for instance, from a hypocoagulable to a hypercoagulable state, making it very challenging to deliver any specific targeted therapy at a specific time point. At present, we have a very biologically heterogeneous sepsis population, and so the quantification of specific sepsis biomarkers can potentially identify treatment-responsive subgroups that are most likely to benefit from specific sepsis therapies. Designing point-of-care testing that can rapidly and reliably identify biologic correlates of clinically relevant outcomes could then be used to randomize patients in a precision-guided clinical trial to minimize the heterogeneity in treatment effect. And we are making great progress. A recent prospective observational multi-center clinical study confirmed that a whole blood interferon gamma ELISA spot assay could identify immunosuppressed septic patients who are at very increased risk for mortality. Low interferon expression, consistent with an immunosuppressed endotype, discriminated 180-day sepsis mortality better than the usual IL-6 and procalcitonin serum levels. The Immunosep-RCT is a first-in-class paradigm of precision medicine for immunotherapy in sepsis, enrolling patients with bacteremia and pneumonia. Patients are randomized to personalized therapy tailored to immune signs of either hyperinflammation or immunoparalysis, respectively, or to placebo immunotherapy. 280 patients have been enrolled to date, with a trial end date proposed of 2025. So in summary, research priorities in surgical sepsis are many, including those we have discussed here today, and separately those in specific types of surgical infections. We still have much work to do, and thank you again for the opportunity to participate today.
Yeah, thank you so much. That was a presentation by Lena. Very quickly, the importance of early clinical suspicion in the diagnosis of sepsis from Halden from Colorado. I won't go so much into introductions. Let's just get right into it. And please have your questions in the chat. Welcome, Halden. Thank you so much.
Thank you so much for giving me the chance to present today. My topic really applies to the surgical setting that we've been discussing in this hour, but I think will also be a nice bridge into the next phases of this conference, because this is a topic that applies wherever we're diagnosing sepsis. I am an associate professor of pediatric emergency medicine at the University of Colorado, so many of my examples will be from children in the emergency setting, but the lessons apply broadly. So as we know, early time-sensitive treatment is life-saving in sepsis, but we cannot deliver the bundle of evidence-based care without first making a diagnosis. In one study that we did looking at children who had not received a timely care bundle, we sought to identify the specific elements that contributed the most to failure to deliver care. And it turned out that delay in recognition or diagnosis was the largest contributor, causing up about half of the failures to deliver timely care. In fact, there's a lot of power in saying the word sepsis. In a study by McAllister et al. That looked at more than 20,000 patients with sepsis who were transported to the hospital, only 18% of them had sepsis recognized before they arrived at the hospital, either by calling ahead from the ambulance to the hospital or saying the word sepsis at the time of hospital arrival. But in those patients where sepsis was diagnosed before arrival, the odds of mortality were 0.82, or reduced by 18%. Furthermore, this effect was magnified when multiplied for how severely ill the patients were who had sepsis recognized early. An adjusted odds ratio showed an odds of mortality of 0.68, reduced by more than 30%. Okay, so clinical recognition is helpful, but how can that intersect with these more modern predictive tools that have been developed? Well, actually, just last week, the US government's Agency for Healthcare Research and Quality released a systematic review that looked at manual paper-based screening tools or automated electronic health record screening tools for sepsis. And this study only included those that had been compared to another standard care. Looking in the last 4 years of studies, they identified 15 studies that rigorously compared a screening prediction tool to usual care. And they found studies that included 4 different settings: the adults in the pre-hospital, emergency, or hospital setting, and neonates. Unfortunately, my population in pediatrics didn't have studies of sufficient rigor to be included. And they looked whether these prediction tools improved outcomes, adherence to clinical guidelines, hospital length of stay, or mortality, and found that when rigorously evaluated, no difference was seen when a prediction tool was implemented, or evidence was insufficient. There was only one population where prediction tools made a difference, and that was in neonates. And interestingly, the outcome that was improved by implementing a prediction tool in neonates was adherence to clinical guidelines, specifically reducing unnecessary antibiotic use. So it was not giving care in a more timely way or to more patients who needed it. It was the reduction of unnecessary antibiotic use. So why aren't these tools working? Essentially, either the tools aren't performing well enough, their test characteristics aren't strong enough, or clinicians don't trust them. And specifically, if they're alerting clinicians after clinicians have already made a diagnosis, they further distrust the tool even more with increased use. What can help this? In the pediatric emergency setting, tools that have been implemented that combine clinical judgment with a predictive model have produced better test characteristics. Why is this the case? If we think back to a Fagan nomogram that encourages us to use tests considering pre-test probability and post-test probability, we can understand why. A pretty good predictive tool or diagnostic test is considered to have a positive likelihood ratio of about 10. If we applied this pretty good tool to an emergency department waiting room where maybe 1% of patients would ultimately have sepsis, this pretty good tool would diagnose sepsis about 10% of the time. Clinicians using it would recognize that 90% of the time it was producing a false positive. If we added clinical judgment and only applied this tool when clinicians had noted a fever, expressed some concern, ordered a blood culture, let's say the clinician got the population to a pretest probability of 10% of having sepsis. Well, then that tool would have a post-test probability of more than 50%, meaning it was right more than half the time, and clinicians would likely trust it more. How do we take this idea and put it in practice? In one study by Balamuth et al., this is how they combined computers and clinicians. Their computer detected patients who had a high heart rate for age and asked the nurse to then answer some additional questions. The computer combined the answers, both from what the computer itself had and what the nurse had identified, to identify only the patients at the highest risk for sepsis. This triggered the clinicians to form a huddle together, again, bringing physicians and nurses to the bedside to evaluate the patient together, consider this higher risk, and determine their next plan of action. I also developed a system to do something differently, but instead of starting with the computer, we started with the clinician. When clinicians indicated they had a concern for sepsis, started a sepsis evaluation, we had validated predictive models running behind the scenes to identify patients at high risk of shock, 30 minutes and 120 minutes after they arrived. When a high risk of shock was met, the alert displayed to the clinicians, and the provider ultimately made the determination of whether to act on the recommendations of the clinician. We tested this in a prospective cluster randomized stepped wedge trial in 4 emergency departments. And we found, unfortunately, like every other study in that systematic review, that there was not an effect on our primary outcomes of reducing the rates of shock or improving delivery of a bundle of care. But we did notice something interesting. Although turning on our model did not change the time from recognition of sepsis to antibiotic delivery, we did notice that our 4 ED sites delivered antibiotics at different rates, despite being 4 sites that had all been engaged in sepsis quality improvement for a long period of time. What was different about the sites? We had to consider the context. The site that was consistently delivering antibiotics the most quickly had inadvertently established a better nurse-to-patient ratio than any of the other sites, and also was the only one with a dedicated 24 hours a day emergency department pharmacist. It turned out our predictive models really couldn't overcome the effect of clinician suspicion for sepsis and ability to execute treatment plans. So perhaps this leaves you a little bit pessimistic about the future of predictive analytics, but I would argue it shouldn't. There is still a role for clinicians no matter how good we make our models. And I'd like to share some data from the Improving Pediatric Sepsis Outcomes Collaborative that was conducted in more than 40 children's hospitals in the US. And between 2017 and 2020, we looked at patients who were compliant with an initial treatment bundle for sepsis, more than 7,000 patients who had a significantly reduced risk of mortality. What was in this magic bundle that they were compliant with? Just 3 things: timely bolus, timely antibiotic, and using any recognition method. Specifically 3: a huddle, clinicians gathering at bedside, an order set, or a screening tool. Formalizing the recognition of sepsis in a system saves lives. And we should continue to use clinical suspicion while we work on the accuracy of our predictive tools. So we need to recognize the strengths and limitations of existing diagnostic tools and use strategies of clinical pretest probability enhancement and using screening tools to bring clinicians to bedside and make decisions about the individual patient in front of them. And I will pause and take questions. Thanks for your time.
Thank you so much, Professor Halden. I will start with, there are questions that came earlier, and thank God you're pediatrics. And one was about the role of neonatal sepsis guidelines in septic shock. I don't know. I mean, it's not my area. And then there was one that followed this up. Role of neonatal sepsis guidelines, septic shock in low and middle income countries. That's the first one. As I scroll through the others, we have about 2-3 minutes. Yeah.
The role of sepsis guidelines.
Yeah, neonatal sepsis guidelines.
Yes, I have to say my expertise is not in the neonatal guidelines themselves. Other than that, a lot of the pediatric guidelines have drawn this distinction between sepsis in older infants over 60 days and the diagnosis in the very newborn infants. And it was in those newborn infants that prediction tools were shown to be helpful in increasing adherence to guidelines. And then over that we kind of lump all older babies in with the pediatric guidelines. Okay,
there's another. Are there any markers that help identify pediatric patients in sepsis? Are there any that are specific to pediatrics? Yeah.
I think the combinations of markers and the way they've been combined into predictive tools do incorporate differences in children. There really, many of the same markers are included that would be included in adults. So combinations of vital signs, normally existing labs such as white count, bands, ANC, lactate, all of those same things are helpful in children, but are combined with different weightings, and then the vital signs are adjusted for age. So I've published some, but so have many others, combinations of factors that might be helpful in children.
Yeah, thanks, Prof. So, okay, because I'm really trying to sieve through the questions because of time, but one key thing is the issue of malnourished children and sepsis. I'm sure even in the US, you do come across some malnourished children and sepsis. So the question is about what are the differences between the malnourished and the what are considerations in that population?
Well, certainly in systematic reviews, having malnutrition and measures of malnutrition is associated with worse outcome and being more likely to have sepsis. And then I think there are key considerations about the use of fluid resuscitation in those children. And part of why some of the sepsis guidelines have recommended a different approach to fluids and much more caution with fluids in children with malnutrition.
Okay. So the second last question, there's a patient representative from the Netherlands. Can parent-patient stories help out? This, I suppose, is with regards to pediatric sepsis. And this is a patient representative from the Netherlands.
I do think parent and patient stories are really helpful. And this is probably known to everyone on this Congress that the public recognition and understanding of sepsis still is lagging, unfortunately, despite all the worldwide efforts. And there's a particular challenge in children because we know there are many self-limited febrile infections of childhood. So parents are used to treating fevers in their children and may not recognize the signs that something is becoming more serious. So I think telling those stories and work to translate these stories into language that makes sense to parents and lay people outside of the medical community can be really, really helpful, and is an area where all the efforts so far have been important, and I hope that growth continues.
Okay, thank you so much. So the last one was there's a lot of appreciation for the huddle approach. I suppose this speaks to multidisciplinary care. It's just an appreciation. So thank you so much, Prof. Halden. Good to see you. Thank you for presentation. Thank you.
Thank you all.